We have prepared 2 cases, but we are a little bit behind the time. I think we should present only 1 case, and that is a case from a morbidly obese 68-year-old patient. And with this case presentation, we would like to show you how we can work as heart team together and find the right decision for the treatment of a patient with a severe aortic stenosis. What you can see on the right side, that is a 68-year-old female with a very morbid obesity, class 3, with a body mass index of 43. She has a severe aortic stenosis with a mild aortic regurgitation. The New York Heart Association functional class was 3. She presents peripheral edema, and they had the typical cardiovascular comorbidities like hypertension, hyperlipidemia. She has also hypothyreosis, and one important thing is that she has 2 severe non-cardiovascular comorbidities. She has a chronic renal impairment with an estimated filtration rate of 34, and she has a severe impaired pulmonary function with an FEV1 of 53%. Furthermore, she was status post after a lumboischialgia that was 1 week before the patient was referred directly from the external hospital for treatment to our hospital. If we calculate the different scores, we can find that the patient has an STS score of 3.28 and a logistic Euro score of 7.71, and that means this patient is a low-risk patient. That are the echo data. The gradient max mean was 108 to 72. The calculated valve, opening valve area was 0.6 square centimeters. The patient has a systolic pulmonary hypertension, and the left ventricular ejection fraction was good. And I think you are agreeing with me that is a patient with a severe aortic stenosis with indication for aortic valve replacement. The coronaries shows no coronary artery disease. And how should we decide? We have on the left side, the guidelines, and if we look a little bit closer to the guidelines, we can see, okay, the patient has symptoms, and we have the option to treat the patients with a surgical valve or maybe with an TAVI valve. And if we look a little bit closer in the guidelines, we can say, okay, the patient has a severe high-gradient aortic stenosis, but for the choice of intervention, we have 4 main points which we should respect. The first thing is we should treat the patient with a heart team in a heart valve center. We should respect the individual evaluation of technical suitability and weighting of risk and benefit for this patient. And surgical valve is recommended for patients with an STS score lower than 4%, and TAVI valve, TAVR is recommended for patients who are not suitable for surgical valve. And if we look into the clinical characteristic, which is favor for TAVR and which is favor for SAVR, we have an Euro score, an STS score of lower than 4, which favors SAVR. We have a patient which is 68 years old, which also favors SAVR. But if we look in the clinical status, we have a frail patient because the mobility is decreased, and we have also a restricted mobility, and which could have an effect of the rehabilitation process mostly, or if you look at the pulmonary functional status or the renal impairment. So it's 2 versus 2, and now it's a heart team decision. And now we look a little bit closer in the expert consensus guidelines. And the best guideline from my point of view is the ACC expert consensus document, the pathway for transcatheter aortic valve replacement. So we start with the patient selection and the evaluation process. And that is a step-by-step approach. And I would like to show how we decide in Leipzig, or we are performing shared decision-making in this case. We have a heart team, we have the information from the referring physician, and the goal of the therapy is that we would like to